we will read it.
So whether you're watching live on WebEx or the recording on YouTube, you can always turn on an automatically generated transcript to be able to read what's being said. So for WebEx, you can find this on the bottom left-hand corner where the letters CC are located in a box. On YouTube, if you hover your mouse over the video to see the box in the lower right-hand corner, you will see a box that says CC with the letters inside. Click on the CC, which stands for closed captioning, and turn on automatic transcript generation. For those who are on WebEx, you will get a link near the end of each session to request a certificate of attendance for professional development certification or maintenance points. These certificates will be emailed out around mid-December. For those watching on WebEx in a browser, you may not be able to access the chat depending on the web browser you're using. And in that case, you can contact OHCOW using the Contact Us form on the OHCOW website to request the link.
Thanks, Megan. Before we begin, we will pause to acknowledge that today is the Transgender Day of Remembrance. This occurs every year on November 20th in Ontario, throughout Canada, and around the world to honor the memory of two-spirit, trans, non-binary, and gender non-conforming people who were killed due to ignorance and hatred. Results of a national survey on harassment and violence in Canadian workplaces by the Canadian Labour Congress revealed that trans, non-binary, and gender-diverse workers are experiencing higher rates of harassment and violence. The link to the report issued from this survey will be put in the chat so you can learn more about how transphobia impacts the workplace.
I would also like to mention today that November 20th is Canada's National Child Day, also known by UNICEF as World Children's Day. The United Nations Convention on the Rights of the Child outlines a wide range of protections, including specific rights for those under the age of 18 who work by creating minimum standards for them. So here in Ontario, teens can start working at the age of 14. Child workers can also include unpaid students that are completing high school or post-secondary co-ops or participating in trade apprenticeships. Ontario labor laws have provisions around the maximum work hours during the school year, and young workers are more vulnerable to workplace injuries, and OHCOW is attempting to reduce these risks through prevention efforts. To learn more, you can search in your preferred web browser for Ontario Young Workers' Rights, where you'll find Ministry of Labour, Immigration, Trainings and Skill Development's webpage, which will be devoted to health and safety information for young workers, ranging from ages 14 to 25. We'll post that link in the chat as well.
Thank you, Holly and Megan. Today, we'll discuss how to combat underreporting of occupational diseases. Specifically, we will hear tools for identifying research, studies with potential conflicts of interest, such as industry-funded studies, strategies for empowering workers during investigations of suspected disease clusters, and recommendations for system improvement from the worker's perspective. So our first speaker today is Dr. Nathan DeBono. Dr. DeBono is an occupational epidemiologist at the Occupational Cancer Research Centre and an assistant professor at the University of Toronto. His research focuses on cancer hazard identification, risk assessment, evidence synthesis, and methods development for a range of occupational and environmental hazards. So over to you, Dr. DeBono.
Thanks so much, Krista, for that introduction. I'll just go ahead and share my screen, if that's okay. So hopefully this works okay. Just give me a moment. Okay. And I'll just open my deck here. Can everyone see that okay?
Yes, it looks great.
All right, good. Got it right first time. So yeah, thanks so much for having me here. It's an honor to speak at October. So today I'm going to talk about some research that I'm really excited to share on a very important issue about around identifying industry-funded research on carcinogenic hazards and the use of a AI-based tool that I sort of helped develop in collaboration with a team at McGill University to search and identify funding sources and conflicts of interest in thousands of studies that were included in systematic reviews by the IARC monographs program. So really excited to talk about this topic. So just to start and provide a little bit of context. So I spent 2 years, 2.5 years actually, working as a scientist with the IARC monographs program, which is based in Lyon, France. And for those of you who don't know, the monographs program is essentially a program that is part of the International Agency for Research on Cancer, which is a division of the World Health Organization, which convenes expert panels of scientists, physicians, toxicologists from all around the world to get together and review all of the scientific evidence that is out there about whether things in the environment or things in the workplace cause cancer. So they provide these sort of very authoritative and very well-respected classifications and evaluations about the carcinogenicity of many agents. They focus a lot on occupational exposures, and studies of exposed workers are very important in the majority of monograph evaluations. And during my time at the monographs, I sort of gained firsthand experience witnessing a lot of the tactics that industry uses to undermine the validity and interpretation of scientific evidence for hazards or agents that they have a vested interest in being deemed safe. These evaluations by the monographs are cited frequently in workers' compensation decisions and evaluations, and also in product liability and environmental tort litigation in all over the world, really. So the way that this sort of industry influence generally works is that industry will hire and pay consultants to produce studies and publish studies that show their desired conclusions. And this serves to sort of fabricate uncertainty or doubt about the scientific evidence, and amplifies, debates in the literature and sort of create controversies, which is a very effective strategy because, the scientific process, there's a lot of uncertainty that is already inherent in the scientific process. And so they try to exploit and amplify that uncertainty to make our job as legitimate scientists much more difficult. And this serves to sort of delay and diminish and slow down the process of arriving at a scientific consensus about the risk posed by certain agents and carcinogenic hazards. And this is an issue that affects all evidence synthesis review and evaluation bodies around the world, in Europe, in the United States. The Cochrane Handbook on Systematic Reviews in Medicine, the most recent version, now has a section that talks explicitly about financial conflicts of interest as a source of bias in evidence synthesis reviews. Some of these organizations, like the monographs, particularly the monographs, have very strict controls in place to prevent scientists with a financial conflict of interest from participating in working groups. They're not allowed to do that. And they're very sort of aware of the threat that industry-funded research can pose to their process, the integrity of their process. And I think that they do an excellent job at this. So let's just sort of back up, and I want to provide a little bit of context and history for how we sort of got here to be in this situation where, industry is able to sort of publish and amplify a lot of evidence that suits their interests, or that is sort of fabricated or even made up in some situations. And it really all starts with the tobacco industry. I think many people are, familiar in popular culture with the story of tobacco, where the tobacco industry fabricated and amplified scientific controversy about the hazards of smoking cigarettes. This started, back in, the 1950s around funding studies that, disputed whether cigarettes were even harmful. And then that sort of turned into, creating uncertainty around, well, okay, maybe cigarettes are harmful, but, how much do you really have to smoke for it to be a concern? Maybe only certain people, who smoke cigarettes, who have a genetic mutation or something like that, are at risk. And then this moved on to the industry, marketing safe filtered cigarettes, even though there was no evidence showing that filtered cigarettes, were safer. And then, moving on into the 80s and 90s, disputing evidence around secondhand smoke. They fabricated studies of secondhand smoke. One particular example being the Japanese spousal smoking study, where industry lawyers literally created a study in Japan about the risks of lung cancer among spouses of men who smoked. It's just basically made up. And then, even today, moving on to vaping, the tobacco industry and vaping manufacturers, are already still doing the same kind of work of trying to dispute the science around the health effects of vaping. So this whole story is very well described and summarized, not just for tobacco, but for other occupational exposures as well, in a fantastic book called Doubt is Their Product by David Michaels, who's an occupational epidemiologist who used to head the US OSHA. So I highly, highly suggest reading this book if you're interested more in learning about the story of tobacco and other exposures as well. So a lot of people know, about the story of tobacco and, maybe think, oh, okay, yeah, just the tobacco industry. But other industries were paying attention. And, the model that the tobacco industry used to delay and manipulate scientific evidence about the hazards of smoking has been adopted by other industries as well. And they're doing the same thing, being represented by, the same lawyers, same law firms. And so I just wanted to talk about one sort of example of this, and that is around this issue of asbestos that was used in brake pads on automotive vehicles. Asbestos was used for a long time in asbestos brake pads. The companies knew about the risk as early as the 1950s. Workers who were manufacturing asbestos brake pads in my hometown of Windsor, Ontario, mechanics who were repairing brakes, who were inhaling brake dust, were getting sick with asbestos-related lung disease, asbestosis, mesothelioma, lung cancer. And so, this resulted in workers' compensation claims that were made in Ontario. OHCOW was supporting some of these workers in southwestern Ontario with their compensation claims. But at least in the US, this has resulted in massive product liability lawsuits. The Ford Motor Company has spent tens and tens and tens of millions of dollars funding research to undermine and delegitimize the risks of asbestos fiber inhalation and lung cancer and mesothelioma and asbestosis among asbestos brake manufacturers and mechanics. So, the same exact model that was used for tobacco, the Ford Motor Company, and other asbestos, the mining industry has used and adopted this same sort of, playbook. And I just wanted to mention that asbestos-containing brake pads were still being imported in Ontario right up until the asbestos ban went into effect in 2018. There's evidence from Statistics Canada showing that Canada was still importing asbestos-containing brake pads during that time. So this is still an occupational hazard for people, mechanics and people who are installing and repairing brake pads right here in Ontario. So I just wanted to show an example of what this looks like at sort of a research level. As a scientist or as a physician, if you're reviewing evidence, how does the industry consultants, how does the industry research, sort of appear? So this is an example of a study that was published by someone named Dennis Paustenbach. That name will be important later, so just keep it in mind. And it's a review of occupational health hazards associated with asbestos, the presence of asbestos in brake linings and pads, a state-of-the-art review. Sounds very, official. And they make these very sort of interesting claims in the abstract that I've just highlighted here. These studies clearly indicated that brake mechanics were not at increased risk of adverse health. The chrysotile fibers are too short to be biologically important. And if you scroll down through the paper, way, way down, buried in a footnote somewhere at the very bottom, they thank people who helped them in the acknowledgements. And then they say, oh yeah, this research was primarily funded by the Ford Motor Company, Daimler Chrysler Corporation, and General Motors. And the authors on this paper were also involved, were paid as expert witnesses in litigation for defendants in the industry. So, it's really hard to see that this is actually an industry-funded study unless you're paying attention. But, just from these two statements that I highlighted in the abstract, saying that something clearly indicates that brake mechanics were not at increased risk. This is not a term that legitimate scientists would really use in an abstract. And we know that this is not true. Lots of evidence has shown this, including one of my studies right here in Ontario, looking at the risk of mesothelioma and asbestosis in the occupational disease surveillance system, which I published a few years ago, which showed an increased risk of these outcomes among people working in motor vehicle repair. And then the whole chrysotile story, this is part of the tactic of, saying, oh, well, yeah, asbestos might be harmful, but not chrysotile asbestos. That's a safer form of asbestos. So, kind of comes right out of the tobacco industry's playbook in terms of trying to disentangle the bad or harmful substance from the, substance that was used in brake pads. But we know that all forms of asbestos are hazardous, including chrysotile asbestos. So, there's a lot of these sort of industry-supported myths that are out there. And I think as, even a well-intentioned scientist or a well-intentioned physician or, anyone, even for workers, it might be easy to sort of fall into these traps of not even believing some of these myths, but just having them sort of like, undermine your confidence a little bit in your knowledge or your expertise, right? Some of these myths are around, a minimum latency of 40 years for mesothelioma, which is just simply not true. And I think many people who sort of make this claim, don't even really understand what the term latency means in this context. Chrysotile is a safer form of asbestos. This was a myth propagated by the Canadian asbestos mining industry and others. Asbestos-induced lung cancer must be preceded by asbestosis. This argument, I think, was also sort of amplified and propagated around for the risks of silica dust exposure in lung cancer and silicosis. But these have been debunked, but the damage is there. It persists in people's minds and can be difficult for people to sort of get around these myths in the literature. Yeah. So I wanted to make the point that, that's one example from, related to asbestos and tobacco, but, these same tactics are used for a whole host of agents. Asbestos, silica, benzene, PFAS, or forever chemicals, talc, which is used in baby powder, pesticides, the pesticide Roundup, which includes the active ingredient of glyphosate. There have been entire books written about the controversy there. Dioxin, lead, polyvinyl chloride. All of these agents, I wanted to point you all to two really important resources: the University of California, San Francisco Industry Documents Library and the Columbia University Toxic Docs Digital Archive. Lawyers who were representing plaintiffs or workers or people who were suing the industry for compensation and liability around their cancers or exposures from these agents obtained documents from industry during the course of those lawsuits and put them all online. And it's really, really eye-opening to search these resources and read internal memos, emails from industry scientists, industry lawyers discussing their strategy and tactics very openly, very overtly for how they were trying to subvert and combat the scientific evidence around the hazard. So I highly suggest checking out these two resources and reading some of the documents for yourself. And so really, this is a multi-billion-dollar product defense industry. That's a term coined by David Michaels in his book, Doubt is Their Product. There are scientists working for these consulting firms that are hired by industry to publish research that sort of, pushes the industry's agenda. There are, a few, just to name a few of the biggest ones. Cardno ChemRisk is probably the most notorious one. Exponent, now Ramboll, has started to get involved, and Talk Strategies, which I think is based in North Carolina. These are consulting firms that are very, very prolific. And a list of just a few authors here whose names just come up again and again and again on industry-funded studies for a whole host of different exposures, just sort of, hired scientists that are just fulfilling the interests and needs of their clients by publishing research that is biased. So here's just sort of an example for people to sort of keep in their minds and just sort of be aware of. Also wanted to mention, just as a pop culture reference, the movie Erin Brockovich with Julia Roberts, one of my favorite films of all time. Cardinal Kemrisk and Dennis Pausenbach are the real life villains that are portrayed in that movie. So that movie was based on a true story of groundwater contamination in a town called Hinckley, California. Well, the water was contaminated with hexavalent chromium, and the Pacific Gas and Electric Company hired Cardinal Kemrisk and Dennis Pausenbach to publish studies advancing their agenda and to fight the lawsuits that were going on around this. So just wanted to sort of point that out. So, okay, so that's a lot of context. But what can we do about this problem? It's very difficult to detect, as I mentioned, industry-funded research in the literature, and if you're not trained or aware of this product defense industry, it's really hard to sort of identify it because they're intentionally trying to sort of keep their agenda hidden, to pass their work off as sort of seeming more legitimate than it actually is, or more unbiased or impartial than it actually is. So I think it's important that workers, scientists, physicians, and lawyers, journalists, know about the product defense industry, especially workers, because this can affect their workers' compensation cases. And really, they're the ones whose bodies are on the line, right? It's their health and their lives that are at stake here. But when I was thinking about, what can we do about this problem, I thought, well, what about ChatGPT? What about AI? Can we use AI to read thousands of studies at a time and identify funding sources and disclosure statements and conflict of interest statements and sort of pool them together and start to build a database to show people, how prevalent industry-funded research is, who's funding what are they working on, just to build more sort of surveillance and transparency around industry-funded research. So that was sort of my question when I went into thinking about this. And I reached out to some colleagues at the McGill University Network Dynamics Lab who were working on a tool that does exactly what I was describing, called Influence Mapper. And I asked them if I could collaborate with them. It's led by Nick King at McGill University. And I said, I'd really like to apply Influence Mapper to some IARC monographs, studies included in IARC monographs, to sort of see how good it is at picking out relationships and kind of seeing what that liked. And Nick said, yeah, that sounds like a great idea. Let's do it. So that's exactly what we did. So basically what I did to start was I assembled PDFs of 2,000 studies that were included in the IARC monograph evaluations for cobalt, benzene, and aspartame. So this means all of the PDFs that were, epidemiological evidence, so studies of cancer occurring in humans, animal bioassay evidence, so tumors and rodents, those kinds of studies. This works is all of those studies were first parsed by a machine learning model called Grobid, which reads the text from PDFs and then feeds that text in bits and pieces to OpenAI's GPT-4 large language model, which reads all of that information and understands it and classifies it for you. So starting with the machine learning part of processing the PDF, Grobid went through all 2,000 PDFs and it read the back matter of scientific articles. So this refers to all of the text in an article that's not the main text of the paper, author names, author affiliations, acknowledgement sections, conflict of interest disclosures, funding disclosures, footnotes, et cetera, et cetera. And it looks and it sort of read and parsed all that information. So you can see an example here for a study that was funded by the International Tungsten Industry Association. This was a study of cobalt for the cobalt evaluation. You can just see here below a snapshot of what the machine learning model is reading. Yep. Oh, what's that? Slide issue?
We lost your slides for a second. We can't
Is there
see
an
them
issue
anymore.
with my slides?
We can't see your slides.
I'm not sure. Try to. Can you guys hear me?
Yep, we can hear you.
I can't hear. Oh, froze for a moment. Okay. Am I back?
We can hear you.
They are back. Okay, we're good. We're good. Okay, so can you see my slide? I cannot hear you guys.
Oh, you can't hear us?
Okay, so can you guys see my slides?
Yes, can see your slides.
Okay, so I will try to pull this back up again. Sorry about that. If I froze for a second, I can't hear anyone for some reason.
We may have to
So
turn off
just
cameras
message
for
me, I
bandwidth.
guess, if
Yeah.
there's an issue. I'll just continue. Okay, so yeah, I'll just continue. You know, just pretend like that never happened. Okay, so moving on, influence mapper. So then all of that parsed information, I hope you didn't miss anything in my explanation, but we can talk about it in the questions after. I'll just continue on. But so influence mapper is, you know, that parsed information gets fed to the influence mapper large language model, and the tool is trained to identify all of the disclosed entities that are cited in the back matter of the study. So industry names, any government agency that funded a study or is mentioned in the article at all gets sort of pulled out by the large language model. And then up to 40 different relationship types are classified between the entity and the study, and each disclosed entity and every author that is disclosed as being related to that entity. So just as an example, the different relationship types are funding the study, reviewing the study, collecting data for the study, performing analysis for the study, or, you know, an example of a relationship between an author and an entity that the tool can pick up are whether that author disclosed receiving a research grant, acting as a consultant, providing expert testimony, or receiving any kind of other funding from that entity as well. So this is an example in this photo of what it really looks like when the tool read all of the studies on from the Cobalt systematic review. And it picked out all of these disclosed sponsoring entities that were mentioned somewhere in the article. And some of these are, you know, academic research centers or government agencies, but it also picked up what you can see here, these sort of other industry-funded institutes or institutions or consulting firms that were identified as well. And so as a human, you have to go through and pull out which entities you consider to be industry funded entities based on your own goals as well. So influence mapper doesn't, you know, decide what is a conflict of interest or what is an industry funded research. It just summarizes all the information for you, and then you have to sort of go through and pick out what you think is important. So this I published, I'll just go through the results from the study that I published recently using this tool and applying it to research on the carcinogenicity of benzene, cobalt, and aspartame. So yeah, I'll just walk through the results quickly, but if you're really interested in reading the paper, you know, please go ahead and look it up. It's open access, anyone can read it and get a sense of what we did. So this is a figure that just shows the number of studies that have been published with any disclosed relationship to industry disclosed in the article for the 3 systematic reviews on aspartame, benzene, and cobalt. And so the green corresponds to all of the studies with the disclosed relationship to industry from the aspartame evaluation. Orange is benzene, and purple is cobalt. And as you can see, the number of studies shown on the vertical axis there, the number of studies has been increasing over time. You can see just before the aspartame evaluation, which was done in 2023, the industry was publishing a lot of studies about aspartame. So you can see that by that green line there, the industry was, you know, a flurry of papers were suddenly published in the literature to try to sort of influence the monograph's evaluation about aspartame, funded by, you know, the American Beverage Association or different industry trade associations. And so this table just shows one of the some of the results from the analysis. And so in looking at, all 2,000 studies that were included in systematic reviews of benzene, cobalt, and aspartame, Influence Mapper identified 39 studies that were funded by industry for benzene, 47 studies funded by industry for cobalt, and 39 studies funded by industry for aspartame, which corresponded to a total of 8% of all the studies for benzene, 4% for cobalt, and 6% for aspartame. So I just want to make the point here that there are a lot of industry-funded studies that are being published on this topic, but they still make up a small proportion of the overall body of evidence, at least that was included in the monograph evaluation. And this is important because I want to make the point that I'm not trying to make the point here that all evidence is funded by industry and you shouldn't trust anything and it's all corrupt or anything like that. It's mostly legitimate, sound science published by researchers who do not have a conflict of interest, who are working for government agencies or academic institutions. The majority of the research still is that, but these industry-funded studies are still influential in amplifying uncertainty, fabricating doubt, and kind of undermining the process of arriving at scientific conclusions. So I just want to make that very, very clear. There were also a lot of industry entities that supplied data to the study, participated in the study. This is a table showing all of the industry-funded entities that funded studies on the carcinogenicity of benzene. So here you can see their names: the American Petroleum Institute, the Benzene Health Research Consortium, the Health Effects Institute, which is in part funded by automotive manufacturers. A lot of these entities have sort of confusing names. You don't really know exactly what the American Petroleum Institute means. It sounds like, an independent, research institute, but it is completely funded by the oil industry. ExxonMobil has funded studies on this, American Chemistry Council, Canadian Petroleum Products Institute, Dow Chemical, Imperial Oil. And so Influence Mapper can quickly summarize and tell you how many studies were funded by the American Petroleum Institute. There were 10 studies published from 1985 to 2016 in these various journals. And just here is another example. These are some results of showing the affiliations of authors who disclosed personal direct relationships to industry entities. So there were authors at the University of California, Berkeley that received industry funding and disclosed it in the papers, authors who were employed by ExxonMobil. There were 9 studies published by authors at the University of California, Berkeley that provided expert testimony for industry on the carcinogenicity of benzene from 2005 to 2016. These are the journals that they were published in, et cetera, et cetera. So just to give an example of sort of what Influence Mapper is capable of doing in terms of summarizing and showing the influence that these different authors or industries have over the evidence, where they're publishing them, how many studies they've published, and over what years. So this is the same thing, but for the cobalt evaluation, and some of these studies were done in workers of at smelters, but the Cobalt Institute, the Cobalt Reach Consortium, these are all industry-funded, bodies or nonprofits that are sort of posing as independent organizations, but they're completely industry funded. Pharmaceutical companies as well, trade associations, IBM Corporation, et cetera, et cetera. So we're showing here how many studies each of these entities funded, what years they were published, and in what journals. Okay, so I'm not sure how much time, how long I've been talking, how much time I have left. So I'll just conclude, because the timer reset when I reshared my slides. So I'll just conclude by saying that, I think tools like Influence Mapper can improve the oversight of bias from industry-funded research on cancer. I think this is a really powerful tool that can bring a lot of transparency to the process of understanding the scientific evidence for workers, scientists, physicians, lawyers, reporters, journalists, judges, things like that. So there's 3 possible use cases I just wanted to mention. I think that this tool can improve, obviously, the detection of industry research and foster transparency in scientific publishing to sort of, as I showed, bring the industry-funded research out in a huge body of evidence. It would take a human many, many hours to read all 2,000 of those studies, but Influence Mapper did it in a matter of seconds. So you can imagine, we could apply it across, huge swaths of literature in the field. The tool, I think, can be really effective for assessing bias in bodies of evidence through stratified meta-analysis. And this has sort of been recommended by the IARC Monographs program, as well as the Cochrane Handbook for Systematic Reviews, to sort of say, okay, well, these are industry-funded studies. What are their results showing? And what are the non-industry funded studies showing? How do those things compare? But most importantly, just alerting and training scientists, especially early career scientists who are new to the field, who may not be aware of some of these issues. And as I mentioned, journalists, lawyers, and workers to really sort of communicate and bring greater transparency and help train them on sort of how these product defense industries and consultants are influencing our understandings of scientific evidence. So I will stop there, and I hope that you all can still hear me.
Okay, can you hear me? Can you hear me?
Okay, I will sign out and come back in.
Okay.
Well, in the meantime, Krista,
Okay.
we'll take a look at
I'll
the
put,
questions.
oh, I was going to type, I'll put questions in the chat, or I'll put them if anyone wants to ask them out loud. I can put them in, but you can type in yourself. And I was trying to talk and think, and I'll put quotes, and that makes no sense. So let me just delete that. So this is the challenge of web presenting sometimes. It's wonderful because we can bring anyone from around the world together to learn from each other, and then you have an internet glitch and we are delayed while we sort things out. So apologies for that. We had a great conversation in the chat amongst a few people. One question that was there was if we could get a copy of the presentation. So after the presentation's done, I'll email Dr. DeBono and ask him if that is possible. It might depend on his employer. So we will ask that. Are you back? Are you able to hear me? I'm thinking not. Can you hear me?
Yes, I can hear you.
Oh, wonderful. So while you were presenting, we had a bit of a conversation and some questions in the chat. So there was a lot of discussion about looking for the conflicts of interest and how sometimes it's hard to find because, as you presented later on, sometimes these are institutes that are funded, and I've definitely come across different institutes, and it could be hard to figure out who is this institute or who is this nonprofit, who is funding this nonprofit. I know there's a Dow DuPont one now funded, so that can be tricky.
Mm-hmm. Yeah, so to figure that out, I mean, a lot of it comes down to, I worked on 2 of these monograph evaluations myself, so I was very familiar with the industry funded organizations that were attending the monograph meetings and observing us. So I just recognize their names, but for a lot of them, just honestly searching online, using those, the Toxic Docs website and the University of California, San Francisco Industry Documents Library, looking up the names of a lot of disclosed entities in those sources and figuring out that they were in fact industry funded institutes. So it still takes a little bit of work. And industry is getting better and better at sort of hiding their involvement. So that definitely still remains a challenge.
Do you think the publishing journals have a responsibility to look at the sources of nonprofits or institutes funding them?
Yeah, absolutely. And it's very common to see authors say that they have no conflicts of interest, but then in their funding disclosure statements say that they were funded by industry and are providing expert testimony in litigation. And usually that violates the terms of the conflict of interest disclosure policy of the journal. But a lot of, I think, editors don't pick up on it and don't identify it, and that's also I think a big problem.
Okay, I'm going to read a question here. Can you please talk about the role of humans in interpreting this data to verify its accuracy? I feel like this used to be the work of research assistants, and although I appreciate how quickly AI can synthesize, there needs to be some checks and balances. So is that something you can comment on a bit more?
Yeah, absolutely. So if you look up the study that I published, we did an entire quality control checking process to check what Influence Mapper was showing us in terms of classifying relationships. And so we identified false positives. There were some false positives that were identified by the tool, and we provided sort of an assessment of the positive predictive value for the relationships that the tool picked up. So to summarize, the tool was almost perfect at identifying relationships between the study and the disclosed entity. There were almost no false positives identified. It may have missed some that were out there, but we were more concerned about saying that there was a relationship when there in fact wasn't. But for the relationships between disclosed sponsoring entities and individual authors, the positive predictive value was much worse. So that those relationships were less reliable, but we did check every single one that was reported in the paper to make sure that it was correct.
Okay, how reliable do you think the AI reading and summarizing tools are at this point in time?
I think they are reliable enough to where the benefits outweigh the cost. The time and effort saved by having information read for you is massive. And you can still, I think you still have to check the information that the GPT model is giving you, but it's much easier to check when it's all summarized for you and you don't have to extract the information right from the primary source. So I still think that even right now that the tools are viable and worth using, but I think that the tools will improve significantly in the coming years as well.
Use it with a grain of salt. Always check things, I guess. I've heard that also how good of an information you get from the AI, especially with the language learning models, is based on how much you put into it. So if you give it a generic question, you may not get more of a specific answer, but if you spend some time, sometimes even a few paragraphs or pages framing what you want, that can help with your answer. Have you found that when you've used it?
So the way it works is the lab at McGill trained a custom GPT large language model. So it's not like Chat GPT where we're just like asking it questions kind of thing. This is a like enterprise grade trained, customly tuned GPT model that the McGill team trained on a training data set of 8,000 scientific articles, medical articles that were coded by humans, and then the model then was trained on that information to replicate what the humans did. So it's actually it's even more sort of accurate than the version of ChatGPT that we're used to sort of interacting with.
Okay, so we also have a question about false positives of influence, like a family member working for an industry, which could influence it. But I think that is difficult to prove.
Yeah, so I'll just say that there are still challenges with this, in that a lot of people, it has been an issue in the past where industry-funded consultants just don't disclose their conflicts of interest. They don't disclose their funding, and that's still an issue. And we need more stringent enforcement of that in scientific publishing. It's a challenge, but I think tools like Influence Mapper can help journal editors enforce their policies to make sure that everything is being disclosed, or to have ghost written articles or industry funded articles that don't disclose that information be redacted after they've been published, which has happened for studies published by ChemRisk on the carcinogenicity of benzene at the Journal of Occupational Environmental Medicine.
Okay, well, thank you very much. I don't see any more questions. I think I got them all in the chat. Is there anyone who wanted to unmute to ask? Okay, go ahead. I see Alexander Medley's hand raised.
Thank you for your presentation. I just want to ask, how do you feel this technology can be used in the future to assist injured workers or workers affected by chemicals on the job?
Yeah, so yeah, I didn't get a chance to get into that too much at the end of the presentation, but I have, after the study was published, I connected with a lawyer who represents plaintiffs and workers seeking compensation in the United States for mesothelioma and asbestos-related disease, and he was super excited about this tool because in in the courtroom or in legal cases, he's trying to show that a lot of the studies that the industry defendants are relying on were funded by industry and have these biases and limitations. So he was really excited about sort of having a tool like this to systematically make the industry influence over a body of evidence more transparent to help in those product liability lawsuits for compensation and things like that. And I think that they can also improve the transparency in the evaluations that these authoritative evidence synthesis bodies make, like the US EPA or the IARC monographs program, to make sure that industry-funded research are not undermining the confidence in their evaluations, which then are used to support a lot of those legal cases and compensation cases for workers as well. So I hope that answers your question.
Yes, thank you.
And I think there is one more hand. Katrine, if you'd like to unmute yourself, go ahead. Perhaps not. Oh, there you are.
Hi. No, I just had put my hand up to confirm that we could hear him.
Oh, all right. A legacy hand.
Perfect.
That's great. Krista, any more
I don't see any
questions?
other questions. We had a great chat in the chat during this and some great questions after.
All right, so I think we'll move on then to our final speaker for today, Dr. Sarah Rhodes. Allow me to introduce her while she comes on camera. Dr. Sarah Rhodes is an occupational epidemiologist, a microbiologist, and an advocate for worker-driven research. She was trained at the University of North Carolina, where she conducted research in partnership with agricultural workers to evaluate their exposure to antibiotic-resistant bacteria from concentrated animal feeding operations. In 2019, Sarah began working with OHCOW as project director to employ epidemiology as a tool for investigating health concerns raised by Ontario workers. In her downtime, Sarah enjoys spending time near the water and cooking delicious meals with family and friends. Welcome, Sarah.
Hi, everybody. Can you hear me all right? I hope so.
Yes.
I can.
Yes.
I
Okay.
can.
Okay, great. If there's ever an issue, just let me know. I'll try to check the chat as I'm going, just in case. But let me go ahead and share my screen. Alrighty, and if I can get confirmation that you are seeing just the slides, we'll see in just one moment.
The slides and just
is that
yes,
is that all right? Is that coming up?
Yes, looks like the
Okay.
presenter view. Yes, it's all good.
Perfect. Okay, great. Thank you so much. Well, I'm so glad to be here, everybody, and it's great to see such an awesome turnout at October today on the 20th. My name is Sarah Rhodes, and I am a project director at OCCOW, as Megan previously said. But today I'm going to be following up with Dr. DeBono's talk to really bring some even more kind of worker-driven examples of how under recognition and under reporting of occupational disease is so prevalent and the factors that influence this issue. And we'll definitely be speaking about the role of worker health clinics in this process of improving recognition and reporting of occupational disease. So with that, I'll get going. So to provide an outline, first I'm going to talk about the factors that drive under recognition of occupational disease. I'll be really hoping to bring forward the worker perspective, at least from what we hear through workers coming to our clinics across the province. I'll speak about how OCOW is trying to develop clinic-based solutions to these issues, and then hopefully open up for some questions and discussion. But first and foremost, speaking of the worker perspective, I just wanted to provide some context around the images on the right. We have on the top a really powerful photo of the McIntyre powder miners who were non-consensually exposed to McIntyre powder in their careers in the mines up north. And then down below, we have a photo of the historic rubber workers in tire manufacturing in the Kitchener-Waterloo area. So when we're talking about the underreporting and underrecognition of occupational illness, I think the biggest challenge is how we can be addressing this question that workers come to our doors with every day, which is there a connection between my work and my health? And the reason why this question can be so difficult to answer is that there are so many different contributing factors that can contribute to our health, especially given the fact that we have spent so much time at work, but we also have other environments that we move through throughout the day and throughout our lives, including on the right, our home and community environment. So we have air quality in our home communities, air quality in our work communities. We have workplace chemical and other like chemical physical exposures or hazards. We have also mental and psychosocial conditions, such as harassment in the workplace that can come into play. We have personal health behaviors and our own kind of personal health factors. And then we also have things like family history of illness that can impact how we move through and develop illness in our lives. So we are really, when we're trying to answer this question for workers around there being a connection between a workplace exposure and health, we are also needing to consider the influence of a lot of these other factors, but while also really understanding the workplace itself. So I will move from here. And so the first piece that I wanted to really dive into is underreporting of occupational illness. So when I say this, it really is truly simply that workers reporting illnesses that they experience at work, and especially also the role of also employers in supporting workers in doing that in the system, the Ministry of Labor, OCOW, other organizations, primary care providers, understanding and reporting illnesses that may be connected to work when we see them coming through our doors. So there's factors here that I'm going to walk through, but the first on the left is that oftentimes we see underreporting of occupational illnesses because it is so difficult sometimes to recreate our exposure history throughout our working lives. So oftentimes, especially for me as a young person and as a young worker, when I was 16 working in a restaurant, I did not have the education or information to know that I should be tracking what I'm exposed to in the job that I'm working at age 16, not to mention moving forward in our lives, especially if you don't have access to that type of information. So oftentimes workers aren't tracking exposures that they're experiencing in the workplace themselves, but also that's something that we've really seen that's important from the standpoint of systems in place to help workers doing that, including employers, keeping records of what exposures exist in the workplace and safety data sheets, et cetera, providing training around those things. So, and especially when we're looking at studies in studying these issues, it can be difficult to actually really create that exposure history. So that's one major issue. The other piece is lack of educational resources and training for primary care providers. There's a growing body of physicians and other care providers who have been provided with environmental and occupational health trainings to basically provide information to them around when they see patients coming into their clinics and they see potential illnesses coming forward, that they are also asking the workers about kind of an environmental and occupational sort of questionnaire for the workers they're working with. Or in that case, they're not even necessarily seeing them as workers, they're seeing them as patients who are coming in. And some care providers may not even think to ask about work and the role of work. So that's something that we really need to be working on and ensuring that that is brought forward as a priority in order to increase the reporting at the clinics themselves that are not even an occupational health clinic. We also have been in the Ministry of Labor and OHCOW, and a lot of the other health and safety organizations, we are very much tasked with improving OHS trainings. And by OHS, I mean occupational health and safety trainings for workers and employers to just raise awareness about the fact that your work can contribute to health, and that is the environments that you are in do influence your body. So that's something we know is a factor that might influence underreporting. There's also issues that we've seen, especially in the clinic, where workers will come forward with issues around access to the compensation system. Sometimes people will say, you know, I believe that there's a connection between my work and my illness. However, I have heard that there's long wait times at the WSIB. I've heard that there's, you know, for some workers who don't speak English or French as their first language, they fear going through the process at the compensation board without translation services that are appropriate or timely will prohibit them from ever reporting something, especially in the compensation system. And then staffing issues. So we've seen those come forward at the clinics. Underreporting can also be driven by inequity and intimidation. We've seen that workers have come in and said, you know, I'm intimidated to report an illness that I'm experiencing because I'm afraid I will lose my job, or there's kind of misinformation around what will happen to workers if they do come forward with an issue. Intimidation has been reported to us of people experiencing that, which is also a mental health stressor. We also see a lot of research coming forward about inequity, which I'll speak to on the next slide. And then lastly, another issue that's come forward in our clinics related to underreporting is that oftentimes, unless there's workers who, especially for conditions that are more rare, unless workers are speaking to each other and kind of hearing more about the fact that, you know, I have a rare form of a disease and I see that 4 of my coworkers do, and I wonder if that's a signal of something. Oftentimes rare conditions are really, really missed. And sometimes people think, you know, this is a rare condition. My doctor told me it's a rare condition. There's no way it could be related to work, for example. So those are hard to capture, as well as severe illnesses. We've had workers come to our clinics who've said, you know, my father had a severe neurological condition and we just didn't have the capacity to ever even apply for WSIB given the nature of the condition itself. So there's lots of factors that come into play with underreporting that we really need to be opening our eyes to and developing solutions for. As far as underreporting, I just wanted to pull a couple of statistics and information that have come forward recently to really highlight some of the pieces I just mentioned in the last slide. So the first is accessibility limitations for vulnerable workers specifically. The Institute for Work and Health have conducted research. So the top 2 pieces here are from the Institute for Work and Health, that newcomer workers especially are more likely to work in physically demanding jobs, be exposed to occupational health and safety hazards, and lack adequate access to protective workplace policies and procedures. Specifically, you'll hear more about this next week at our October sessions, but we have seen workers who, you know, especially if they do not have a clear, you know, time or ability to, or you know, especially the language issue as seen here, workers are intimidated to go through the process of even reporting their illness. They do not go forward, and especially newcomers facing a lot of issues that they are facing, this is even more of a barrier. And specifically for the language piece, in the Institute for Work and Health research study, more often the study team heard of medium and small size employers trying to overcome language barriers through more informal means as opposed to formal services, such as using online translation apps, pairing newcomers with buddies who speak the same language, or asking family members to help interpret OHS training and onboarding sessions as opposed to that coming from the employer or through an official translation service, for example. So those are things that could also suppress reporting of illness. The compensation system setbacks, I've mentioned a few that we hear from workers, but we've also seen that there's been more reports at the WSIB as of late related to reports amongst their staff of understaffing, as well as long queues, where I think even workers at the WSIB who've reported that they've felt that burden too of worrying that people are waiting a long time while they're also experiencing injury. So we've seen those 2 come forward in recent data. And now I'm going to move towards I spoke about underreporting. Now I'm going to speak about under recognition. So when I speak about under recognition, I really mean now some of the kind of moving into what Dr. DeBono was speaking about, how do we see ways that are put into place where connections between a disease and illness, or a disease and work, are suppressed or under-recognized by the system, by research, and so these are some of the ways that I'm going to speak about now. For under-recognition, one of the first issues is truly biases and limitations that are inherently present in some of the occupational health research that exists. A lot of times we're dealing with retrospective exposure research studies where we're really, again, trying to study plants that sometimes, for example, have closed, and there's only a limited amount of information where you can maybe only look at the influence of working in the industry itself, not necessarily having a lot of information about specific exposures or specific departments. So that's something that we see that often that can lead to potentially under recognition over time. I'm speaking here to influence from industry funded studies. So this is one that Dr. DeBono spoke to, and I think that's a very interesting piece that in the work that he's done to really show that, if we can create tools that allow us to stratify systematic reviews based on industry funded studies versus non-industry funded studies, and see if that does shift results. Even in the compensation system in Ontario, that would be an interesting tool for us to be considering moving forward to try to reduce or eliminate the ways that might bias results. Another piece is one that we see is limited I put EPI here. EPI is epidemiology, so limited education amongst sometimes occupational health consultants in the field of epidemiology, and the ability to actually break down and understand research results and interpret them and synthesize the evidence coming out of groups like the the International Agency for Research on Cancer, et cetera. So that not only is the need for potentially physicians, as I was speaking to before, or primary health care providers to have more occupational health training, but also even amongst occupational health physicians, being able to boost the training in epidemiology, especially if they're commenting on evidence synthesis for claims, especially. Lastly here, I'm going to speak about a couple of others. There's been more discussion as of late around frameworks for causation. And when I say causation, it really is basically, for example, if a worker files a claim, the end point where someone is deeming, yes, this disease caused this, or this work that someone was doing caused this disease. There's been there's a lot of different models that have been created over time in the scientific field in order to better assess causality or causation between diseases and exposures. However, sometimes, especially from an epidemiology perspective, these criteria can be applied inappropriately, which actually, if some of you have seen Dr. Demers' report on the use of scientific evidence and principles in work compensation or workers' compensation or work-relatedness of cancer, that report I'll also show on a slide coming up, but that is one that these topics are very much more discussed, and I'm happy to answer more questions on those. But then lastly, we have also, in a similar vein, sometimes to the rare conditions I spoke to before, sometimes because rare conditions are so underreported, they also are under-recognized, given that the standards that are for causality applied to those conditions can be the same as for other conditions that are more common, which is sometimes can make it so that those are very highly under-recognized, even though rare cancers, for example, compile and make up almost 20% of all cancers coming forward in Ontario. So there's a lot of these issues that need more attention. As far as under recognition, I just wanted to pull, again, some statistics to kind of speak to some of those points that I just brought forward. At the top here is the report, a copy of the name of the report I just spoke about with Dr. Paul Demers, that I was lucky enough to be a part of preparing the scientific section of this report alongside Dr. Demers. But this report does really bring forward some of the issues around under-recognition or the potential for under-recognition of occupational disease. This chart here shows that in a cancer burden study that was conducted by Dr. Demers and the team, there was specific exposures such as asbestos, solar radiation, diesel engine exhaust that were, they looked at the predicted number of cases that we would expect to see in Ontario, and then compared that to the number of accepted claims that we actually see through our compensation system. And you can see really a discrepancy here that starts to reveal itself. For example, with asbestos, 140 predicted cases were predicted, and then only 80 accepted claims came through. For solar radiation and illnesses associated, 1,400 predicted cases, only 24 accepted claims. So you can really see the discrepancy here and potential for under-recognition of occupational illnesses. The next piece I want to talk about is actually related to our kind of evidence synthesis process, and again, kind of answering from the compensation, especially the compensation board, but also just the scientific community. How do we actually answer the question of, is there a connection or association between certain illnesses and a certain work environment or work exposure? And the International Agency for Research on Cancer, the group that Dr. DeBono just spoke about, recently published a publication that's called Bias Assessment in Case Control and Cohort Studies for Hazard Identification. I would really, really recommend people, especially at least read the first chapter. It's very it explains the IARC monograph process and how they really synthesize evidence across different types of illnesses and exposures, but also very much describes how we can better understand how to interpret the evidence coming out of that group. But what was really striking to me was that in the first paragraph, the first chapter of this issue, they really spoke about how over time we really see evidence build for connections between specific diseases and exposures. So for example, at the IARC, they usually will classify kind of the strength of evidence into sufficient evidence as one of the higher categories, and then limited evidence based on the level of evidence present. But I'm just going to read these quotes directly. So over the 52-year history of the program, there have been many opportunities to examine this question in detail. During this time, a determination that there is sufficient evidence of carcinogenicity in humans for at least one cancer type has almost never been reversed. So this is powerful because truly when IARC has deemed something to have sufficient evidence, it's never usually over time had evidence come forward to reduce the certainty in that decision. So sufficient evidence really, once something is deemed to have sufficient evidence, it really continues to stay in that category. But then also the next one is even more powerful. For agents with limited evidence, so some of the disease and exposure or disease workplace associations that we see that have limited evidence in humans, such as arsenic and dioxin in this case, as time has gone on, the evaluations have advanced. Generally, they do advance to sufficient. So also this is something that I think is really important in the under-recognition of cancer, especially cancer-related relationships. We do see that truly like time and there being more and more research coming forward. If something has limited evidence, generally over the history of the monograph program, there's been motion towards sufficient. So I think that that's something that sometimes we see that the limited evidence category can be interpreted. If we interpret that in the context of time, that is a really important point. So all that to say, kind of to wrap up this piece, underreporting and under-recognition really go hand in hand. You can imagine that if we have underreporting of illnesses, then ultimately there's not going to be as much evidence that can be even available, and that will lead to under-recognition. But also we've seen that when something is under-recognized, so for example, for workers who've gone through and there being rare conditions where there's maybe limited evidence of a connection between the workplace and the illness, if something's under-recognized, sometimes that can discourage people from reporting it. So you can see how these kind of go hand in hand and they really drive each other. But also I put at the base, I think it's really important that what we've seen as well is that inequity, discrimination, and intimidation in the workplace drives both of these. And it really is one of the biggest issues that is needing support, as well as kind of under-resourcing of the occupational health and safety system in general. So I want to now move into kind of talking about how we are trying to address these issues at OCCOW. But first, I'd like to really take a moment to touch on the worker perspective. So This is a compilation of a lot of different news articles that have come out about various workplaces that people have come forward with concerns about their health. Some of you who've worked with OCOW or know about OCOW and the work that we do, you might know of the stories of the General Electric Peterborough plant, Venture Plastics plant, the rubber worker group, McIntyre Powder, exposed miners, among many others. We work with many different groups. In the middle of this slide here, there's been more and more work with nail salon workers who have concerns about health. So there's many different worker groups have really come forward and brought and put themselves on the line to tell the stories about what they're experiencing at work, and also to really speak out about the injustices that they've faced in going through the health and safety system and going through the workers' compensation system, and trying to drive change and drive policy change as well, and combat underreporting through speaking out. So I did just really want to recognize that this is where we've been driven from. I wanted to also speak to this particular example just to show that, you know, truly there's a lot of these pieces about underreporting. It's so powerful to see some worker groups that really come together and in community have started to either sense something is wrong, seeing people at their workplaces get sick, coming together, telling their stories collectively. And this is one example, the Venture Plastics plant in Peterborough. This is a really powerful photo because Rose Wickman and Jackie Duffy, who are two workers at the plant, had compiled obituaries of their friends and families as they start to see people pass away from cancer at a rate that they would expect was higher than what you would think was to be normal. So it was really powerful. This image was published in newspapers, and their stories were published, and they were really brave to put those out, and also came to OCCOW to ask for support in investigating these issues. So really underreporting is so driven also by workers coming together in community with one another to seek support, even though it should not be that we have to wait for workers to get sick in order for this to happen. So, and not only is there the workplace issue, I just wanted to also say that for this particular plant, there's been more and more markings of Environmental Protection Act violations. So even communities neighboring the plant have been complaining of sense of like for VOCs and other issues. So that's something that it really does show again the example of not only does our workplace health impact the environment, but the environment impacts our health as well, and neighboring communities can also be suffering. So that is just one example I wanted to raise. And so now what I wanted to do is go through just an example of, in order to better show you kind of how OCCOW is hoping to combat underreporting, underrecognition of illnesses, and support the kind of advancement of interventions on these issues. I wanted to just go through and show you an example of one of the projects that we've been working on, and really just to highlight our process and what we're hoping to continue to do, and of course get more feedback from many parties in how to do this even better moving forward. But if you do not know of OCCOW, I'm sure many of you do here, but we are a network of occupational health clinics across the province. We have clinics in almost every major city in Ontario, and we have a really unique group of staff members, including client service coordinators, occupational health coordinators, nurses, physicians, hygienists, ergonomists, as well as product directors and executive directors. So we have a very wide breadth of skill sets at OCCOW in order to try to help people answer these questions. Specifically, is there a link between my illness and my work? And also, how can we improve safety in the workplace, first and foremost, especially if people are still working? So one of the services that we have provided over time for a long time is what we call an occupational disease cluster investigation. So some people may not know what a cluster actually means, but I wanted to break that down for everyone here. So a cluster is basically a group of people. So you could think about a group of coworkers or people who all work at the same plant in a shared space. So for example, a workplace or a neighborhood, who have developed a shared health problem. So for example, say there were 10 out of 200 workers in a plant that all have kind of shown up with a rare cancer, and there's concern growing at a higher rate than expected. So for example, maybe we would only expect to see 1 out of 200 people diagnosed, but we're seeing 10, just as a very simplistic example. And then also over a certain period of time. So it's also, in order for something to be deemed a cluster, it also needs to be over a certain period of time that we're looking at this kind of higher or elevated rate of a certain illness amongst a group. So that's how it's defined, but we have worked with workplaces who expect that they have clusters of illness in their workplaces. And one of the groups we've worked with is the group of rubber workers that are in the Kitchener-Waterloo area. So just to provide some history, one of the main kind of ways that we try to capture and also combat underreporting of illness is through something that we call intake clinics or an information session. So in 2002, the United Steelworkers hosted an intake clinic and started engaging OCCOW with issues that rubber workers were bringing forward around their health. And in 2019, there was a much larger intake clinic that involved OCCOW, USW, and the WSIB, where over 300 workers presented with their family members to basically document their stories of the illnesses they were experiencing, the exposures that they were experiencing. And then since then, there's been a huge process of the claims that have been put in the compensation system for rubber workers to work through those and better understand, is there a clustering of illness here? What do the illnesses look like? How do we determine that? But also, how do we make sure that rubber workers can come forward and report illnesses and that this is not an underreported area? So we've continued that work, and we just actually had a info session in 2025. This past fall. I wanted to just show a photo of the team. So this is our team, including our hygienists, physician and director, client service coordinators, and nurses. So we had almost 40 workers come to this last session, and that's on top of the workers we already have in the growing database of rubber workers. A few other examples of intake clinics. We've had a session with the plastics workers. There's in this photo, you can see specifically Jackie Defty, Sherry McFadden, who are two of the workers who've been really active, as well as our team members. And then I wanted to show another example of the intake clinic we held with McIntyre Powder Miners, very much led by Janice Martell. But really the powerful piece about these intake clinics, which I think is definitely the gathering of workers to share their stories in community and to capture those stories from the disease perspective, but also from the exposure perspective, and trying to do that really hard work of trying to recreate the exposure history that has occurred in a certain industry or in a specific plant, so we can really get a better idea of what was going on in order to see if we do actually see connections between certain illnesses and certain exposures or working in a certain area of the plant. But also not discriminating against workers with any particular illness, and describing the kind of process as we go very transparently. So with the rubber workers, we are only here really with them because of their voices. They have come forward and have experienced various types of cancers, including GI cancers, prostate, lung, bladder, hematological, head and neck cancers, respiratory issues. You can see that the list goes on, and this worker group has really suffered from many, many different illnesses. Some of the information that we also tried to gather in order to address the kind of under-reporting, under-recognition are looking at the workers, if workers do decide to put in a claim, which sometimes they do not want to, given various aspects. So for example, so that's also one where we're still tracking their information, even if they don't want to put in a claim, to combat that piece of underreporting related to just not wanting to go through the claim process. There's the highest number of cases we've seen were GI cancers, and you can see here the red is the number of those cases that were allowed. By allowed, I mean they were accepted as having connection to rubber work in the compensation system. But you can see that there's also a large majority of those that have been denied and were not deemed associated with the rubber industry. So we are able to kind of see across the different illnesses, the kind of difference by the way that they are kind of deemed connected to the rubber industry or not. And we are very much using the expertise of our entire teams to better understand whether or not those associations are, have a deep level of evidence that should be going forward as an accepted claim. But yes, so we are going to keep going from here. Let me just do a little time check too for myself. So I'm wrapping up here, but basically what we want to move forward with and really speak to is that for worker support, it's very important for us to combat underreporting by collecting health and work histories, creating a database of worker stories, ensuring that they're able to have the resources that they need to connect to the legal system and the claims support system, but also most importantly, if they're still working, to ensure that they have access to educational resources. We also are creating a database that is allowing us to better understand if there are diagnoses or kind of are diagnoses that have gone through into the compensation system that were denied that actually are potentially that there is evidence available that would show that there might be a need for an appeal of that decision. For example, we're reviewing scientific evidence. If we are finding trends coming forward, we're hoping to publish our own studies as well. One example is actually related to a rare condition that as I mentioned before, if we weren't doing these intake clinics, sometimes I think we would really miss some of these rare conditions. In the case of rubber workers, it's salivary gland cancer. This is a very rare cancer, and we've seen more of these cases come forward in the rubber industry. And I think if we weren't capturing them at OCOW, they might have slipped through the cracks. So I just wanted to show that one example. And so I'm going to wrap up here. This is my final slide. But I think the key takeaways from our OCOW process are that we really want to combat underreporting and underrecognition through the early and comprehensive evaluation of workers' concerns, actively listening to workers, respecting their experiences as a form of evidence, especially through our intake clinics, documenting the diseases, exposure, stressors that they have brought forward, but also really making sure that we're transparent in that process, that of course there are so many different factors as well that come into play with each diagnosis. So just mostly trying to inform people, if there is not enough evidence at this moment related to a certain illness and work, we want to explain to workers why that might be true, provide resources, better describe what's going on so that they are not left out to dry in understanding the research that is out there and that exists. And we also hope to work with partnerships as best as we can. Like partners at the OCRC, the Ministry of Labor. We have partnerships with unions and other researchers too. And then lastly, on our website, we have many resources that we're trying to continue to create in order to get information to workers to really also break down some of those barriers related to vulnerability and discrimination, but also even, for example, language barriers. So next week, I'll just put the plug that we'll be speaking about vulnerable workers, and our program manager, Eduardo Huesca, will be speaking about a lot of the projects that we're working on with agricultural workers specifically. So I hope you will all be able to join for that. And with that, that is my final slide. I'd like to thank you all so much. Specifically, there's many people on the slide here to thank, but thank you. Thanks to the Ontario workers who have entrusted us with their stories. A couple of names: Gord Assman, Rose Wickman, Jackie Duffy, Sue James, Janice Martell are some of the workers who've really been strong advocates who've helped us better understand how to serve workers. But also I'd like to really thank Dr. Paul Damaris, Dr. Kathy Slavic, Kate Witt, Holly Houston, and Kimberly O'Connell for helping and develop these kind of resources around cluster investigations that you've seen on these slides. And then thanks again as well to Dr. DeBono for sharing knowledge on the influence of industry-funded research. And with that, I will close and go over to questions.
Okay, thank you, Dr. Rhodes. Before we go to questions, I'll just mention that those around WebEx who have access to the chat can find the link. They'll have to scroll back a couple of questions, but it is there, so you can provide us with feedback. You can also use that form to request a certificate of attendance for professional development. Those will be emailed in mid-December. And I will start by going through briefly some of the questions. I answered at least one. First question was around, do we come across cultural problems in reporting with injury or saving face? They gave the example of some regions of the world, and I already responded, so I'll just briefly say, yes, we do find in Ontario, we have construction workers, contract workers, temporary foreign workers, recent immigrants from some countries who are reluctant to report for a variety of different reasons. One is because the job may be precarious. One is they don't want to look bad. all sorts of different reasons. I am not aware of a paper that would help look for how to encourage reporting, but it is something that OCOW is doing with some of our temporary foreign worker outreach. So David, who asked that question, will definitely be interested in attending next week. So it'll be talked about more.
Great.
The next question is wondering about whether the healthcare system does or could identify cases of Schedule 1 cancers like mesothelioma for follow-up. Sarah, is that something you can talk about briefly? That might be potentially our only question for time.
Yeah, so it is interesting. I absolutely think that there's use of, if in kind of expanding our reach into the healthcare system and also using administrative health data to better track cases that are coming forward for targeted follow-up, for example. However, I think what's coming to mind for me is that the best example of this is actually Ontario has a lung cancer screening program. So we've been trying to actually work with kind of proactively reaching out to workers who meet the criteria for lung cancer screening in order to then ensure that they're accessing those screening programs, especially if they work in high-risk industries, and then from there encouraging or supporting with reporting if they do in fact have a diagnosis of lung cancer, being there as a support to guide them through that process to understand what it would involve to go through filing claim, but mostly and most importantly, regardless of the claim process, ensuring that they have access to prevention, further prevention resources that they need. So that's just one example I'll provide for now.
Okay, we do have time for one more question. It's from Denny. Hi, Denny. Nice to see you. Are there any other databases or initiatives that can complement? My thing just reset. Okay, complement the information that OCA has on tracking WSIB accepted or rejected claims in rare cancer. Do you think a province-wide database might be feasible?
Yeah, well, it is really interesting. I think that we're always looking for ways to ensure that OCOW's data is also just more, I think OCOW's data alone is more accessible. We're really working on developing out our collaborative health record or electronic medical record system so that we can have more in-depth analyses. We're also working with new tools like REDCap, if some of you have heard of that, to track and more systematically gather work history information, health history information, so that we can do analyses of those and potentially even look at looking at a broader way of working with others to make a province-wide database, for example. So I think that's a great question. And, of course, we're working with groups like the OCRC who have even more access to health data and other tracking systems. We've been working to try to look at also working with hospital connections, at Unity Health, et cetera. So I think that it is feasible. I think that there's a lot of talk about expanding our data capacity at the ministry overall across all of the health and safety systems. So I think, Denny, you're on the right track, and that it's now just more about organizing and getting the momentum for it.
Okay.
But thank you for these questions.
Okay, I just invited anyone who still has questions to use the OCOW Contact Us form to mention their question to Dr. Rhodes, and then you would get back to them.
Perfect.
I hope it's
Yeah.
okay. I volunteered you to do that.
Feel free. I also I am happy to I'll just put my email in the chat. I do not mind if people want to write me. So thank you so much.
Okay, well, with that, we'll close the session. Thank you, Dr. DeBono and Dr. Rhodes, for your time today. And I hope that everyone's appetite has been whetted and will come back next week to learn more about vulnerable workers.
Thank you, everyone. Thank you, Krista.